Today we'll discuss the disorder of the urethra, so to complete the disorders and the congenital anomaly of the urinary system. Previously, we get the disorder of the bladder and disorder, renal disorder, renal disorder, bladder disorder, and urethral disorder, and now they will get the urethral disorder. As you know, the urethra, it is the structure, tubular structure extend from the bladder neck to the external meatus, and it is about 15 centimeter in male, and it is divided into two parts: anterior urethra and posterior urethra, and the anterior urethra divided into two parts also is the penile and the pulpar, and the second part, or the posterior urethra, divided into two parts also, it is the membranous and the prostatic. The female urethra is about 4 centimeter, so it is shorter than the male urethra. Now we will get the congenital disorder of the and acquired disorder of the urethra. And the first one is the posterior urethral valve. It is one of the common diseases that involve the male urethra. So when we say posterior urethral valve, it means male disorder. Male disorder. The most common obstructive lesion in infant and newborn, occur mainly in male and are found at the distal prostatic urethra. The valves are mucosal fold that look like thin membrane. They may cause varying degree of obstruction when the child attempts to void. So, what I mean by posterior urethral valve, or PUV, posterior urethral valve, it is a membranous fold present at the prostate, at the level of the verumentanum, at the level of the verumentanum. There are three types, of the posterior urethral valve. Type 1, it is 90 to 95% valve extend from the verumentanum to the fuse anteriorly. Extend from verumentanum and from both sides and then fused anteriorly. Type 2, extending from verumentanum to the bladder neck. مثل البردة، هذا ينزل شلون البردة منها مثل برد المسرح، يكون extend from the verumentanum posteriorly to the bladder neck. And the third one, it is a ring-like membrane found distal to verumentanum. Presentation of the patient. The main presentation during the prenatal care, when the mother go for follow-up prenatal care, seek doctor advice. When the doctor send her for ultrasound follow-up, the radiologist said that the baby have bilateral hydrourethronephrosis. Bilateral hydrourethronephrosis. Dilated bladder and posterior urethra. I mean, it is the prostatic and membranous urethra, dilated prostatic urethra, and oligohydramnion and renal dysplasia. This is the scenario. This is the scenario for the infant or newly born baby with posterior urethral valve. Scenario: bilateral hydrourethral nephrosis, dilated, full dilated bladder, dilated posterior urethra, and also oligohydramnion. The mother complained from oligohydramnion. And also the patient, infant complained from renal dysgenesis. Renal dysgenesis. Newborn baby also, or infant, sorry, newborn infant, an infant, sorry, complained from respiratory distress, palpable abdominal mass, ascites, some rarely ascites, and failure to thrive. This is the presentation or case scenario for the posterior urethral valve, either present or diagnosed prenatally, during the mother follow-up, or a newborn and infant present with respiratory distress, palpable abdominal mass, ascites, failure to thrive, and also the newborn presented with repeated vomiting, electoral disturbance, lethargic, all of this because of the inability to pass urine normally, dilated kidneys, and may present with high or blood urea nitrogen, high blood urea nitrogen. Older children, recurrent UTI, weak stream, incomplete emptying, and sometimes incontinence, and VUR, urethral reflux. So, 3 scenarios for the posterior valve according to the age of presentation of baby. May we diagnose it prenatally, or newborn baby, or older children, when he can get rid of complete obstruction. So if there is complete obstruction and the baby cannot pass urine, presented a new born life or infancy. But sometimes hardly some baby reach older, so presented with recurrent UTI, presented with weak stream or incomplete emptying and incontinence. Investigation to identify at first we start with the ultrasound diagnosis. So by ultrasound, voiding cystourethrogram هو ال VCUG voiding cystourethropy. Dilated posterior urethra and valve leaflet and thick bladder neck. This picture for VCUG voiding cystourethropy. How we can do this? By insertion of Foley catheter and calculate the amount of contrast media that should inject it to the bladder, and then after that remove the Foley, and during voiding we get this picture. So this picture or this exposure show dilated bladder, dilated posterior urethra, dilated bladder, dilated posterior urethra. This sign could be keyhole sign. شوف الشكل مالتها مثل الفتحة مال المفتاح القديم اللي عندكم، هذا الباب هذا الشكل مال الفتحة مال المفتاح يسموه key hole sign. This is diagnostic for the posterior urethra, and also isotope renal scan to assess the function or renal function, and also video urodynamics is very important for diagnosis. Video urodynamics study very important to show the function of the bladder or emptying on the dysfunction of the urethra. Treatment now. The aim of treatment is to bladder drainage and get rid of the urine retention that occur by the valve. If boy born with suspected posterior valve, then treated by drainage and, if possible, immediate VCUG. Drainage either by urethral catheter, either by Foley catheter, or by suprapubic drainage. So the aim of treatment, as I said, it is to empty the bladder and continuous or keep the function of the kidney to stabilize the patient. So after insertion of the Foley catheter or suprapubic drainage of the bladder, the blood urine nitrogen return normal, electrolyte disturbance disappear, and they start the feeding, baby start feeding. At that time, when stabilize the baby, we can complete our investigation. So do VCUG and go for the complete management by valve ablation. And I mean by valve ablation, it is the by resectoscope, special instrument, resectoscope, and we enter through the urethra and remove the valve. When medical fitness is achieved and creatinine is normal, the removal of the valve by resectoscope. But sometimes a newly born infant and unfit for resectoscope removal of or ablation of the valve. So sometimes we may go for vesicostomy. And also some baby may need for higher diversion, divert through the kidney by percutaneous nephrostomy. It is, I mean, drainage of the or direct drainage of the kidney. This is all about the posterior valve, and now we go for new topics. It is the urethral structure. What I mean by urethral structure is an area of narrowing in the urethral caliper due to scar formation and the tissue surrounding the urethra. As I said in the beginning of the lecture, the urethra it is a tube-like structure. To expel or transmit and expel the urine from the bladder to the external meatus. When there is narrowing of this caliper, of the urethral caliper by scar tissue that lead to narrowing or decrease the size of this lumen. It is either congenital or acquired. Most acquired structures are due to inflammation. Remain a major cause, particularly infection from long-term use of indwelling catheters. Any trauma of the urethra or infection that lead to narrowing of it lead to formation of the scar and narrowing of the urethral structure, narrowing of the urethra. Most common cause of that is the infection. External trauma. Throttle injury, a blow to the palpal urethra, and iatrogenic instrumentation. Either throttle injury, I mean by throttle injury, it is the direct trauma to the perineum. Direct trauma to the perineum. So throttle injury. When the men sometimes move in a dark street, when there is rainy weather, water cover the floor, and there is an opening of sewage. When the male lie down, one leg inside and the other leg outside, so there is a direct trauma to the perineum. يعني السيناريو مال الكيس إذا عندنا فد ميل يتمشى بشارع وظلمة ومطر والشارع كله مي، بده يشوف طريقه، فيجي اكو فد مين هول مفتوحه، فيوقع. من يوقع رجل تنزل لجوا بالمين هول ورجل تبقى على الشارع، فبهيك حاله راح يصير عندنا دايركت تراما على البرينيوم. دايركت تراما للبرينيوم يسموها سترادل انجري، هذا المعنى مالت السترادل انجري. And also there is iatrogenic instrumentation. Iatrogenic during instrumentation for any urological intervention. Urethral structures are fibrotic narrowing composed of dense collagen and fibroblasts. These narrowing restrict urine flow. The bladder muscle may become hypertrophic and increased residual urine may be noted. Severe prolonged obstruction may lead to reflux, hydronephrosis, and renal failure. Urethral fistula and periurethral abscess commonly develop in chronic severe structure. Complication: chronic prostatitis, cystitis, and chronic UTI, diverticular, urethral-cutaneous fistula, and periurethral abscess, and vesical caliculi. Clinical findings: voiding symptoms, hystency, poor stream, post-void dribbling, low flow rate, and urinary retention, and also prostatitis and epididymitis. Investigation: urethrogram, retrograde urethrogram, RUG. شوف دائما patient يقول له روح سوي لنا RUG، وريتروجريد urethrograft. retrograde شلون نسوي؟ by insertion of small Foley catheter 12 French only the tip of the Foley catheter to the navicular fossa, and then inflate the balloon by 1 to 2 cc of fluid, and then inject the contrast media to the urethra. Inject the contrast media to the urethra, and after that get the multiple exposure of X-ray and in the lateral oblique position to show the urethra and the side of the length of the urethral structure. Also, we may get benefit from the real-time ultrasound, MRI, and endoscopic examination or cystoscopic examination. Okay. Treatment. Dilatation of the urethra is not usually curative. It fractures the scar tissue. As the healing occurs, the scar tissue reforms. According to the length of the urethral structure, after we do the urethography or retrograde urethograph, RUG, after complete the retrograde urethography, then we find the length of the urethral structure. According to length, we decide the type of management. So, if the length of the urethral structure less than 1 cm, and some said less than 15 mm, we can do dilatation, urethral dilatation, multiple size sound or dilators, metallic sound dilator. Start with the smallest one and then the largest one. So these benefit from this dilatation. We do destruction, forceful destruction of this structure area. After destruct it, sometime there is during the healing process reform the scar. So we should avoid it in the large size structure. Sometimes we need to do cystoscopic or urethrotomy, endoscopic urethrotomy. Previously, they said it is the optical urethrotomy, and nowadays it could be under vision urethrotomy, and also sometimes the long segment. There is a long segment or of the urethral structure. So this long segment surgery, removal of this long segment, and multiple procedures for reconnection or treatment of this structure. Now we go for the other topics. It is the congenital anomaly that could be hypospadias. Congenital anomaly that could be hypospadias. What I mean by hypospadias? Hypo means below. Spadon, it is the orifice. So hypospadias, below orifice. The site of the external meatus below its normal position. The condition in which the urethral meatus or external urethral meatus open on the ventral side of the penis, proximal to the tip of the glans penis. So it is normal. So it's below its normal position. Incidence, it is 1 to 250, and it consists of 3 anomalies: abnormal opening of the urethral meatus, where anywhere located from the ventral aspect of the glans to the perineum; abnormal ventral curvature or chordae; abnormal ventral curvature, the penis of the baby presented with an opening below, ventral curvature. It is called chordae, and abnormal skin distribution. It could the hooded skin. So 3 abnormalities: the opening below its normal position, curvature of the ventral curvature, and hooded skin. Classification according to position of the opening or of the meatus. Either it is anterior, including the glandular, coronal, and subcoronal, and middle include distal penile, midshaft, and proximal penile, and posterior include the penoscrotal, scrotal, and perineal. It is according to site of opening of the urethra opening. Assessment: patient with hypospadias should diagnose at birth, assess the associated anomaly like undescended testis, inguinal hernia, severe hypospadias, or hypospadias with unilateral or bilateral cryptorchidism, or penoscrotal hypospadias should have chromosomal study to exclude the intersexuality. So when we assess a baby with hypospadias, we should assess the position of the testis. Sometimes patient presented with hypospadias, severe type of hypospadias. So it is called the penoscrotal congenital anomaly. The opening of the urethra located between the penis and scrotum. Bilateral and descended testis. Deficient scrotal skin. Deficient scrotal skin creases. This baby should investigate it for chromosomal study to exclude the intersexuality. Okay. Treatment: for psychological reason, hypospadias should be repaired before the patient reaches the school age. In most cases, this can be done before the age of 2 years. Now we go for the epispadias. It is vice versa. Epispadias, it means the distal urethral or external urethral meatus go dorsally. Hypospadias ventrally. Epispadias dorsally. Okay, so the opening go dorsal to the shaft or to the penile shaft. Most female with epispadias are incontinent. The pubic bone are separated as an ecstrophy of the urinary bladder. Treatment by surgery. Treatment by surgery. So the epispadias, the opening dorsally. Very important point. Patient with hypospadias continent. Patient with hypospadias continent. Patient with epispadias mostly incontinent. Patient with epispadias mostly incontinent. The pubic bone opened or displaced from the pubic symphysis, something like the open book, and may associated with excess trophy, especially so it is congenital anomaly with multiple defects. Now, phimosis. What I mean by phimosis is a condition in which contracted foreskin cannot retract it over the glands. The scenario for this baby present history of uncircumcision, recurrent infection, urethral discharge, redness of the skin or of the foreskin, sometimes swollen, and appear with inability to retract the foreskin backward. This phimosis, chronic infection from poor local hygiene, it is the most common cause. Calculi and squamous cell carcinoma may develop under the foreskin. Phimosis can occur at any age. Edema, erythema, tenderness of the prepuce, and the presence of purulent discharge are usually presentation. This is the case scenario for the phimosis. شباب لازم نفرق بين الphimosis والparaphimosis. It is very important. This is the scenario for phimosis. Uncircumcised male, uncircumcised with edema, erythema, tenderness of the prepuce, and presence of purulent discharge are usual presentation. Treatment. The initial infection should be treated with broad spectrum antimicrobial drugs. The dorsal foreskin can be slight if improved drainage is necessary. The dorsal foreskin can be slit for improved drainage if necessary. Circumcision should be done after the infection is controlled or subside. Paraphimosis is the condition in which the foreskin, once retracted over the glands, cannot replace its normal position. It regarded as urological emergency. Consider urological emergency. Why? The scenario of paraphimosis, baby presented by his family, complained from inability to pass urine, severe pain, swelling, redness, ugly looking glands. The family give history that the baby is uncircumcised, but now the glands appear not covered by the prepuce or not covered by the foreskin. So the family said he is not circumcised, but now the glands not covered by the foreskin. So the skin go back and cannot replaced to its normal position, retracted backward, and cannot return to its normal position. It is considered urological emergency because this retracted foreskin act as a ring that lead to increased edema and cut the blood supply to the glands. Cut it like a ring, constricting ring that cut the blood supply to the glands. So it is considered a urological emergency. This is due to chronic inflammation under the redundant foreskin and formation of tight ring of skin when the foreskin retracted behind the glands. The skin ring causes venous congestion. Treatment of consists of manual compression of the edematous tissue with a subsequent attempt to retract the tightened foreskin over the glands. Dorsal incision or dorsal slit of constrictive ring may be required or circumcision. Now we go for the circumcision, routinely performed in some countries for religious or cultural reasons. There is higher incidence of benign carcinoma in a circumcised male, but chronic infection and poor hygiene are usually underlying factor in such instance. Circumcision is indicated in patients with infection, phimosis, and paraphimosis. Okay, thank you.